Hello there, I welcome you today. My name is Dr. Elisa Shipon-Blum. This is me, and I am the President and Director of the Selective Mutism Anxiety Research and Treatment Center, or SMART Center, in Jenkintown, PA, right outside of Philadelphia. I'm also the founder and director emeritus of the Selective Mutism Association, formerly the SMG. I'm also a director of the Selective Mutism Research Institute, as well as an assistant professor at Philadelphia College of Osteopathic Medicine. I've developed the evidence-based treatment, social communication anxiety treatment, and I am so excited today to talk to you about what is SM. And one of the reasons I'm talking about this today is that I want to dispel myths, and I want to give you a perspective that is based on thousands and thousands of children and has been researched. There's lots of information around, and there's a lot of misinformation. So I'm super excited to talk to you about what is SM. Here's what I ask people. What is SM? Do you know a child who is mute, barely whispers to a few in school or other settings, but is able to speak in other settings such as home? If the answer is yes, this child may be suffering from selective mutism. One of the things that you're going to learn from me today is I don't really like the term selective mutism, and you're going to hear why I don't love that name. I can't really change it because that's the name that exists, but children aren't just mute. Some do whisper, some whisper to a few, some are completely shut down. So when I hear what is SM and it's just about mutism, it kind of makes my blood curdle. So I'm going to just tell you that children with SM aren't just mute. So I'm going to start out that way. And an interesting thing that I'd like everyone to do today is to take what you know about SM just for this time that we're together and kind of put it aside. Kind of go into this with a super open mind, because I really believe that when I'm done today, you're going to see SM from a whole different perspective. So I'm going to talk about the diagnostic criteria, its relation to social anxiety and other comorbid disorders. We're going to talk about the factors into the development and maintenance of SM, the etiology and presenting symptoms, the importance of an early diagnosis, what is SM and what is it not, and I'm going to talk to you more in depth at the end about SCAT, what it is. Let's go over the diagnostic criteria. Why? Because I think it's important. It is classified now as an anxiety disorder. Yay, it wasn't for so long. It was actually classified as an other disorder of childhood. So now at least it's under an anxiety disorder. It's a consistent failure to speak in specific social situations. Okay, we know that, right? Where there's an expectation to speak, although they can speak in other situations. The disturbance interferes with their ability to function in the educational setting, in the work setting. When people ask me questions like, well, isn't it just a severe form of shyness? My question is, a lot of shy children do function. Children with SM, although many of them have shyness to them and social anxiety, which we'll talk about, their ability to function socially, emotionally, academically is impaired. So this disturbance, SM, has to affect it in a way that their functionality is affected. The duration has to be at least a month. Why? Because a lot of kids in the beginning of the school year can be quiet and timid and avoidant. So we want this to be a kind of 1 month type of standoff. So if a child is kind of quiet and they weren't so quiet before, we kind of tell families, wait it out like a month or two, let's see how he or she is doing before we make any decisions on SM. The failure to speak is not due to a lack of knowledge of the language, and the disturbance is not better accounted for by other disorders. One of the reasons that I don't completely agree with some of this, because children with SM have comorbid issues, coexisting conditions that actually create a social communication anxiety, or SM. So you'll hear me talk about this today. So in the DSM-5, you can see here that it's a complex childhood anxiety disorder. Children are able to speak and communicate in settings where they are feeling secure or comfortable. Although I have plenty of kids that I see and teens who are very, very comfortable, but they're mute. So it isn't always that they're comfortable. So please know that it could be that they look almost like a professional mime, some of these children. And that can be kind of confusing to people because they don't look anxious. I highlighted that SM is a social communication anxiety disorder that has factors into the development and maintenance of SM. I'm going to repeat this. SM is a social communication anxiety disorder that has factors into the development and maintenance of SM. I repeated it and you'll hear it again. Why? Because that is the premise to my life's work. As a physician, I wanted to understand, and I started to realize pretty early on in my career that kids with SM are not just mute. So there's factors into the development and maintenance of SM which have to be addressed. If I could, in a perfect world, I would rename SM a social communication anxiety disorder. So what I ask that you do is see it that way for right now because it's going to make sense. We can call it SM, I'm fine with that, but it's a social communication anxiety disorder. The typical presentation that we think about is a timid, early elementary child who acts in a socially appropriate manner with family members, close peers, and relatives, but is mute or barely whispers to a few people in school. They may be shut down in public settings if a waiter or waitress asks them something. That's the typical presentation. That's what I call the dictionary case. I can tell you that there's many, many that don't present that way. So if you're here because that doesn't completely make sense to you, that's good because I'm going to give you reasons as to why children present other ways. So how do they manifest? How do children with SM manifest their anxiety? Well, not all kids manifest their anxiety in the same way. Some may be completely mute, completely shut down, well, in one setting, but then see that same individual who might be questioning them in another setting and warm up and talk. So it will change from setting to setting and person to person. Some may be fearful, shut down. Others may look relaxed and carefree. Some may socialize with a few children. Some can be functioning in a full group and present and actually read a script, but not be able to communicate and answer a question from somebody else who asked them an individual question. Many of these children have difficulty engaging with others. Simply handing money to a store clerk or a pencil to another child can cause tremendous anxiety. They may have difficulty responding and or initiating in even a nonverbal manner. So here we are talking about selective mutism. And I'm telling you that many of these children have great difficulty engaging with others. Even nonverbal communication can be challenging. The actual fear of speaking for some individuals is so tremendous, they look like a deer in headlights. So the fear of speaking becomes reinforced as we try to get a child to speak. Those that know me and know of my work, I don't focus on the mutism. I try to understand the child. And you'll learn as we move along as to how we do that and how I use what we call a social communication bridge. But when we emphasize speaking too much to a child that can't even engage or communicate comfortably non-verbally, we're actually reinforcing their anxiety. Why does a child develop this? Well, most of us know that the majority of children with SM have a genetic predisposition. We've done studies on this, and we see that those that have a genetic predisposition tend to have stronger anxiety within their family, such as social anxiety. So we see that. Some of it's passed on, learned, as well as genetic, and we see it. Over 90% of the children or teens that I work with, young adults, meet the criteria for social anxiety on paper. But here's something I'm going to tell you. I don't agree with the 90%. I think that's high. I think on paper they look like they're socially anxious, but many of these individuals aren't really afraid and uncomfortable with the people in the situation. They just can't effectively socialize and communicate for a variety of reasons that we're going to talk about. So I believe 90% is too high. And I'm sure there's people here today who are thinking, you know, you're right. The child I'm here about isn't that shy. I know so many shyer, more timid individuals. But yet this child has selective mutism. Why? I want to talk about that. Many children with SM do have that severely inhibited temperament. So that's no doubt about that. And again, we see that often. And that gives you the idea that shyness is a way to relate to those children, and they often relate to that. I don't like children to identify with being a shy person because then they take on that persona. However, many of them have severely inhibited temperaments. Approximately 30 to 40% of children with SM have subtle speech and language abnormalities, such as receptive and/or expressive language abnormalities. And we've done studies on this to show. As children age and remain mute or minimally verbal and communicative, what do we think happens? Well, individuals who may not have been delayed in their language can develop an acquired speech and language disorder. Why? Because if you don't use it, you lose it. So the older the child is and the less give-take of communication, we will see kids that may have met the milestones on time, but have developed an acquired speech and language difficulty. Typically, it's in the area of narrative expressive speech, when you're trying to explain something, when you're trying to be initiative and expressive, what the movie was about, what the book was about, what do you want to do today? WH-based questions can be difficult, not because they couldn't do it before, but because they're not used to it. Typically, as children become verbal with SM, they speak in 1 to 2 quiet words, usually direct. Answering to direct questions is easier than open-ended. They're rarely initiative. I have many kids who become verbally responsive, but they can't even initiate non-verbally. So know that speech and language difficulties can arise, but maybe they were delayed in their speech and language. So the history of these kids is very important. Some children may have met the criteria for a speech and language disorder as they were when they were younger, but then received treatment or they became developmentally appropriate, but there was a lot of expectation for speech. So although they may not meet the criteria for speech and language, they have a speech and language difficulty that has stayed around because it either wasn't addressed or it's been reinforced, meaning trying to get a child to speak when they weren't able to. We did a speech and language study on 33 children who exhibited different types of speech and language challenges, and this is what we came up with. 42% had speech articulation issues, 27% had an expressive language, but you can see some receptive and expressive language issues, and so forth, some fluency issues. So if a child, and we said 30 to 40% have these challenges, have a speech and language disorder, how can we try to get them to speak if we're not necessarily addressing their speech and language? So I think that's important to think about. Other reasons why a child may develop SM. Well, I see plenty of kids in my practice where they have some learning difficulties. They have difficulty starting, completing tasks on time. Certain concepts are very difficult for them. Some of them, more commonly, have processing disorders. So processing disorders are the most common learning challenge that these kids have. What is really important for us to do is to differentiate a true learning challenge with anxiety. Meaning, are they anxious from being socially anxious? Do they have sensory processing challenges, which we'll talk about? Do they have language issues? Why are they having a difficult time starting and completing tasks? Are there other difficulties going on and challenges? So before we diagnose a child with a processing disorder, with anxiety, your processing slows down. It's like slow motion. So we need to make sure that we're not misdiagnosing, that we're not saying a child has a learning difficulty when they don't, a learning disability, a learning difference. We need to determine, is it a true learning difference? Or is it an anxiety that's from other reasons and causing the child to have challenges within school? I have many kids that are bilingual or multilingual. Some of these individuals have spent time in a foreign country or they've been exposed to another language during their language formative years. usually between 2 and 4 years old. It's not uncommon to see a family that was raised by their grandparents that spoke a specific language, and they weren't entered into school till they were 5 years old, and then all of a sudden they're in an English-speaking preschool or an English-speaking elementary school, and that ability to translate the language, if they're speaking another language wholeheartedly at home, almost 100%, that's really challenging. So for many of these kids, they're going through what we call a normal silent period, where they're trying to digest the language, translate it back. And some of these kids are being kind of asked to speak, and it becomes this big deal, and what was a normal silent period becomes reinforced, and they develop almost a fear of speaking, and SM can develop from that. I had a family recently who was speaking 90% Chinese at home until the child was 5 years old. She watched TV, but most of her environment was Chinese. She went into an English-speaking school, and the parents came and said, she's selectively mute. We don't know what to do. And my first question was, but you're speaking Chinese at home all the time. She needs to have practice in this other language. So we definitely need to work on building the language skills as a child is going to school in. And of course, these behaviors become learned and conditioned. I want to talk to you about sensory sensitivities and sensory processing disorder. I'm really excited about this in the way that there's a lot of kids I work with that have these sensory sensitivities, and it's not known. They don't understand the connection. And we see it. We've done research on this. It's a range between being a highly sensitive person, or an HSP, which is a child that tends to be very perceptive, very aware, often very empathetic. They feel deeply. They know who knows, when, where, and how. They're sensitive to tags and things and maybe picky eaters, but they don't necessarily meet the criteria for having a sensory processing disorder, but they're very sensitive to their environment. Those kids are almost what we call hypervigilant. They will react quickly. They'll shut down. And I will often tell families, those kids tend to have the most difficulty in loud, large, and lots of people environments, the 3 Ls. So children with SM tend to avoid or shut down that deer in the headlight look, just like you see here in this picture. Those kids are shutting down from kind of an abrupt sensory effect on them. And so it's something that we need to understand. These are the things that I see in my practice. These are the most common. I use a diagnostic questionnaire in my evaluations. It's called the Selective Mutism Comprehensive Diagnostic Questionnaire, or the SMCDQ, and we screen for sensory processing challenges in there, as well as many other disorders. But why I'm saying that to you is these are the areas that I'm going to go over with you as to where I see it the most. I see children very sensitive to feel of fabrics, hairbrushing, washing and hugging, hand-holding, and being touched. Often they pull out tags from their clothes. They prefer elastic band pants compared to button pants, tend to be picky eaters. Sensitive to sounds, lights, or smells, sounds being the most common sensitivity. And many of these kids have what we call emotional regulation challenges. They will go from 0 to 60 in a matter of a few minutes. They may shut down quickly. They may react. They may have tantrums. They tend to act out. They cry easily. Parents will say they're very difficult kids to parent. So some of these kids have these emotional regulation challenges. When I'm mentioning some of these things, even this being socially withdrawn and tend to misinterpret touch in the classroom, they can be kind of sensitive, where they may say somebody hit them, but the child may have just brushed past that child. They feel that they're pushed or prodded and they don't understand. So this could be their sensory sensitivities, and know that when they're in a classroom and feeling anxious, it can make their sensory sensitivities that much more pronounced. The reason I'm going such into depth with this is that I don't know how to treat a mute child without understanding all of these factors into who the child is. If a child has sensory sensitivities, learning challenges, emotional regulation difficulties, with or without sensory issues, we've got to incorporate that into our treatment. This particular screen is kind of difficult to see, but what we did here is a study on sensory issues, and we found that most of the kids with SM tend to be sensory avoiding children. So they tend to avoid situations, and they rarely are seeking these sensory seekers. Interesting, we found that visual processing was the area that was the most affected with these kids with sensory challenges. So I thought that was a pretty interesting factor, that they tend to be having some visual processing challenges. And I noticed that when we do testing on these children, we tend to see some of these kids with visual processing difficulties. I do see kids with auditory processing issues as well. And that can come across here in the classroom when the child doesn't process everything the teacher may be saying, so they're missing important things, whether it's directions to an assignment. They may become behind academically because they're missing steps because they weren't able to keep up. These kids tend to be more withdrawn. They tend to play alone or not playing at all. They tend to be more hesitant in responding, even non-verbally. Many of these kids become distractible because they can't necessarily keep up with some of the directions auditory-wise, or they get overwhelmed, so they seem distractible at times. They might get up and fidget around. So following directions and staying on task may be a difficulty. Is it an ADHD, an ADD? Is it a processing disorder, a learning difficulty? Is it a sensory child? So this is why understanding the child is really, really important, especially within the academic setting where we're trying to develop accommodations and interventions. In the real world, many of these kids with sensory sensitivities will become avoidant. They'll shut down. They'll tune out others. Again, the 3 L's, loud, large, and lots of people environments. So we're going to want to do our treatment and expose the child in quieter, smaller, less people environments. Why? Because it's going to help the child feel more successful as they're able to function better. So our experience here at the SMART Center and the Selective Mutism Research Institute, or SMRI, dictates that sensory processing difficulties may or may not cause learning or academic difficulties. And that's something that we want to think about as we are planning for 504s and IEPs. So key points about the etiology of selective mutism and the symptoms. Symptoms may not exist in a comfortable and predictable setting, such as at home. They may not. The child may seem fine at home. It's not until their environments that challenge them and their difficulties that you'll see some of these symptoms. And as I said and repeated earlier, there are reasons into the development and maintenance of SM. You will see this orange section of the slide as we move on in this presentation. But again, here are the reasons why a child may have SM and why it may continue. Because if it's not addressed and we're just putting a Band-Aid on some of these difficulties, how can a child overcome their challenges if we're not realizing they have them? Key points about the etiology and symptoms of SM. Selective mutism is therefore a symptom. Interesting, isn't it? That children with SM are rarely just mute, but yet there's such a focus on treating to speak. I don't get it. I don't get it. Children may have multiple factors into the development of SM which can exacerbate their SM. And it's not atypical for a child with SM to be timid, have sensory sensitivities, perhaps a subtle speech and language disorder, while another may be bilingual and timid by nature. Every kid is different, and every kid is a unique soup, S-O-U-P, soup. Not everyone makes chicken soup the same way, so not every kid with SM is the same way. When evaluating a child with SM, in my opinion, this is why I quoted myself here, it's critical to determine the cause as to why the child developed SM in order to develop an appropriate treatment plan and school-based accommodations and interventions. It's critical to understand why they developed SM and reasons as to why it might be being maintained. I believe it's critical because you can treat some children without knowing this, but you can't treat all children without having an understanding. Doesn't that make sense? You can treat some children without understanding at all. I believe you can treat many, but you can't treat them all. Studies have shown there's no evidence that SM is related to neglect or trauma or abuse. I'm mentioning this to you because we typically think of abuse as the typical abuse of a child being hurt and beaten. But what is abuse can be different for everybody. What about a 5-year-old child that is being told if she doesn't answer the question, she can't go out for recess? Or you need to talk to your friends if we can't go and have a play date next week. That is difficult. That's abuse in some ways. Because if we don't understand the child and we're trying to get them to do something that they can't truly do, then that causes them tremendous anxiety, which only reinforces their fears. So the definition of abuse can change. So I mention it for that reason. When are most children diagnosed? I mentioned between 3 and 8 years of age. If we're talking 8 years of age, usually it's been there for sure, but the parents may have just thought the child was shy. Typically, it's when a child enters into a social situation that it's first seen. So temperamentally inhibited and severely anxious in social settings as infants and toddlers is usually an underlying factor as to why a parent may go early to see what is going on with their child. A history of separation anxiety and being slow to warm up. I had already mentioned being very shy. That's why people often kind of let this diagnosis go because they think it's just a severe form of shyness. Typically notice when a child again enters into a social situation, such as daycare or school, so depending on when they enter. Teachers often tell parents the child's not talking or interacting with other children. In other situations, the parents will notice early on that their child's not speaking to most individuals. So that's how it usually kind of presents and what the history is from a lot of parents. One of the challenges that I find in my practice is that some parents will be different in terms of their interpretation. You may have one family member who says, I think my child's fine. You know, at home she's totally fine. The other parent goes, but you don't see her at drop-off. You don't see her in school when she's sitting by herself. So it's really important that parents are on the same page because it is going to affect treatment if there is a misunderstanding to the child, because that's going to be important in implementation and success. Obviously, the earlier the diagnosis, the better. Our findings indicate that the earlier a child is evaluated and treated, the quicker the response and the better the overall prognosis. If mutism persists, the child literally gets used to, it becomes a hard habit to break as they become more conditioned. One of the things that I want to tell you is that I'm not about treating a diagnosis. When someone says, is my child diagnosed with SM? I say, yeah, they meet the criteria for selective mutism. We can use that for school-based accommodations and insurance reimbursement, perhaps, but we're treating a child. And treatment isn't so difficult to begin early that you need to postpone things. So the quicker the child is involved in some sort of treatment program, meaning some of this, 80% when the child is very young, is working with parents in schools. If a toddler is SM, you can help them understand their scaries and feelings, as we'll talk about, but really it's training parents and teachers. So if it's not difficult to do that, why would we want to wait? I will see individuals who are 15, 16, 18, 19, 25, 50 years old call our office and say, everyone thought I was just shy. And so parents will bring their older teen to us and say, we thought they were going to outgrow it. So if it's not difficult to treat, why wait? As the child continues with any anxiety disorder, if left untreated, they can have negative consequences. I just listed some here. Obviously, anxiety disorders are the most common mental disorder out there. But untreated anxiety leads to worsening anxiety, depression, and other anxiety disorders. Social isolation and withdrawal, poor self-esteem and confidence, school refusal, academics start to go down, possibility of quitting school, underachievement, not reaching their academic potential, self-medication. Individuals who abuse alcohol and drugs, often when you look at their background, it's not uncommon to see they had a history of anxiety disorders. Teen or unplanned pregnancy, suicidal thoughts, and possible suicide. I'm not trying to scare anyone here. I'm trying to tell you that if you have an anxiety disorder that is affecting your ability to function, you don't want to wait. You want to address it. Interesting, I mentioned depression. I don't tend to see that in younger kids. I tend to see many of these listed criteria here for things that occur as anxiety goes untreated as the child gets older. So it's more testimonial to why we want to treat when a child is young, because we want to also help them build the long-term coping skills. Why do so few teachers, therapists, and physicians understand SM? Well, studies are scarce. The great news is more and more studies are coming out there. I'm proud through the Selective Mutism Research Institute that we have many studies out there. We present at conferences. We have graduate students that do the research. We work with them. We put posters together and present to professionals. So there's more and more research getting out there by us as well as other universities. So it's not as rare as it used to be. So it's really important that more and more studies are done to understand these children. If you look at a textbook, there's not very much in there. I can tell you years ago when I looked this up, because I'm a parent that had a child with SM, that I had like 2 sentences in my medical textbook of pediatrics on what selective mutism was, which was a child who refuses to speak. It certainly doesn't explain these children, and it makes them seem willful. So if you're reading a textbook description and it's not updated, or it's just even for people that don't necessarily have a true understanding and they're being asked to write a description, you may get minimal or inaccurate information. Many individuals focus on shyness and outgrowing the silence will occur. That's what they think. So why, they're not growing, they'll be fine. Some may see SM as oppositional and defiant and see these children as controlling and manipulative. Some may see this as a form of autism or an indication of a severe learning disability. I can tell you firsthand that when my child was 5 years old, she was told from her pediatrician with her in the office that she had a severe learning disability. She did not have a learning disability. The person just didn't understand. So, of course, I experienced that firsthand, but I hear that all the time. Here's something really, really interesting. Most blame behaviors on SM, meaning they see SM as the cause of their learning issues, their speech issues, their sensitivities, when in reality, those issues are the factors into the development and maintenance of SM. Interesting. So when I hear, oh, she has a speech issue because she's SM. Oh, she doesn't play with her friends because she's SM. Oh, he's just sensitive because he's SM. He doesn't follow directions because he's SM. It's backwards. We need to see it from the right perspective, that these challenges are what's leading to the social communication anxiety disorder and then being reinforced. How is SM treated? Well, I put in quotes, psychotherapy and medication, which is what some people think and do, to address the anxiety that underlies the person's inability to speak in certain situations. Psychotherapy, in my eyes, is pretty much an open book. It could be any type of therapy, right? So it doesn't really give you too much information, but of course, using therapy is very, very important. Behavioral and cognitive behavioral, CBT, are very common treatment approaches to SM, and we certainly use that here at the SMART Center. But we want to address underlying etiologies and coexisting conditions that we talked about. And many of you who know of my work have heard me speak on comorbidities, coexisting conditions, and so forth. I can't emphasize it enough because it's such a factor into these kids. Medication is certainly used as an adjunct. I don't recommend ever to use medication alone. And I don't recommend going to a doctor or therapist where the first thing they say is, let's go on medication. I think that would help, without having an understanding of the child, because then you're giving medication with the hopes that that child is going to overcome it. And I would say that medication is used as an adjunct. At the SMART Center, we use medication in 10 to 15% of the kids. It's not a high percentage because we rely on the therapy. But as the child gets older, I would say that that percentage increases because the behavior is more conditioned. So let's talk about the treatment of SM via social communication anxiety treatment. That's the treatment that I developed from trying to understand these kids, because I see it and I conceptualize SM as a social communication anxiety disorder. That's what I see it as. So if you now take SM and you switch it in your mind to a social communication anxiety disorder, it opens up so many doors as to how you can assess these kids, but also how do you treat these kids, because you're not treating to speak. SCAT focuses on understanding the whole child. As a physician, that's how I was taught, so I didn't know any other way. That was my way that I was taught to evaluate an individual that came to me in my medical practice, is I wanted to understand why. And so therefore, without realizing it, that's what I did when I was trying to understand these children, which of course started with my own child and, you know, progressed into starting a nonprofit organization, the Selective Mutism Association, to starting to work with families. And as I started to work with families just to help them, I started realizing these kids were anything but just mute. So that whole child approach was how I understood these children from the beginning and just wanted to get it, right? So the social communication bridge, which I'm going to show you, or the stages of social communication, are used within SCAT because children with SM change their level of social communication based on the setting, expectation from others within the setting, and also how their comorbidities affect them in a given setting. There are factors into the development and maintenance of SM that are considered in the treatment plan, and we need to work very closely. Psychoeducation and interventions practiced in the office and then implemented across settings through parents and teachers and other caregivers, in the home, in the real world, and school. Please don't rely on a treatment that focuses on treatment solely in the office with the hopes that when the child leaves the office, he or she is going to just start to progress. Parents need education. Teachers need education. You need to keep tweaking the treatment. You need to keep working on it. The initial intensive evaluation assessment process is meant to answer 3 questions. In my mind, why did the child develop it? What are factors into maintaining and reinforcing these factors? What are those factors? Why is SM continuing? What are the comorbidities, the parenting styles? Parenting styles are critical. You have to have parents in line. If you have one type of parent who's a pusher and a strict parent, and another parent who's very permissive and more of a loose parent, that's going to cause a lot of confusion within the home. So working with parents to help them adjust their parenting styles to support these children in a democratic, authoritative way, that's the best way that we want to work with these kids. What stage or stages of social communication is the child in across settings? Please know that they will be communicating in one way, in one setting, but then in a different way of communicating in a different setting. So why did the child develop it? What are the factors into this? And what stage or stages are they in different settings? I want to know the whys. Here's the bridge. I love it. The bridge is my favorite thing about what I do, because in addition to the whys, I want to understand the child's baseline level of social communication in different settings. And then we can develop the appropriate strategies and implement them in areas of the child's life. Is the child in stage 0? The typical scenario is a child's walking around the grocery store, talking up a storm to their parent, or sitting in a restaurant talking to their parent or siblings. Waiter might be right behind them, but the child's talking fine. It isn't until the waiter addresses them that the child shuts down, goes down to what we call stage 0. Stage 0 is a child that shuts down, freezes, or a child who actually looks kind of comfy but doesn't interact and almost ignores others. Maybe you know a child like that. She or he can have a conversation with his parent or someone he's comfortable with. You try to interact with that child, and they act as if you don't exist. That child isn't able to communicate with you. So it's how the child communicates with someone else that dictates their stage. So a child that's talking to their parent, yeah, they're in stage 3, verbal. But if that another person that they're not as comfortable with interacts with them, what is that stage? That's the question we want to know. Out and about at home, with relatives, peers, with a plumber who comes over. Some of these kids can talk fine with someone that comes to the home that they don't know, but can't even answer their grandparents' question. So stage 0 is a child who's not communicating. They're not responding. They're not initiating. Stage 1, given time in any setting, most children will progress into nonverbal. They may not be quick. They may be quite hesitant, but they will progress into responding by pointing or initiating, maybe. We often need to work on the initiation, even nonverbal, by prompting the child. But most children will progress, given time, into nonverbal. Stage 2, which is the missing link to treatment, I call it that because we think once a child is comfortable, that child is going to progress into speech. Well, guess what? Not all of them do. In fact, many of them don't. That's why this transitional strategy was made, because I couldn't figure out early on why everyone was saying this kid should just start to talk. They're not talking. They must be defiant. And I realized that they weren't able to. So I realized over time, working with thousands of kids, that there's ways to help the child that you can use very strategically to help the child progress from nonverbal to verbal communication. One way being a verbal intermediary. What is a verbal intermediary? A verbal intermediary is someone that the child can speak to, or maybe an object for a younger child, like an action figure or a puppet, but typically a parent or a peer or someone the child can speak to. It doesn't have to be completely conversational, but they can use their words to that person. So using a verbal intermediary around someone they're mute with is really great, because the child begins to use his or her words towards that person by using a verbal intermediary. The example is, child's at a restaurant with his parent, and the waiter comes over. The child has his visuals, his chart, his things written down, what he wants. So he sees that. He knows what he wants in advance. He doesn't have to think about it. And the waiter comes up, and the waiter says, "What would you like?" And normally the child's completely shut down. Now the parent turns to their son and says, "Hey, do you want a burger or pizza?" Something so simple as a simple forced choice question may be all it takes, but for many, it doesn't even work that way. So what we need to do is perhaps, do you want a burger or chips? Whatever that choice might be, with the last answer being the right answer so the child hears it, may have to lean in and say, "Tell me." So do you want a burger or chips? Tell me. And so you start using this. Again, sometimes it's done incrementally. Sometimes the child just starts to quietly respond. And there's lots of parenting goals and things like that that we use to help the child progress into verbal. But the verbal intermediary is a wonderful way to help the child, bringing him into conversation in settings that they're mute. Another example is the child sitting in class. Maybe they're writing an assignment, and the teacher comes up and says to the child and a peer, because of course small groups and buddies are very important, "Did you want to study the government or the environment, guys?" And the one child says the government, and the other child, who's selectively mute, isn't going to answer the teacher. So the teacher says, "Did you want to study the government or the environment?" And then tell Rebecca, prompts her to tell her peer. So that's a very viable strategy for the right child to use, and then the teacher's instructed to repeat without eye contact. Some simple strategy like that can work wonders for many children. So we want to be able to understand what transitional strategies will work. Sounds to words is another one. I can work with a young child and literally put some sounds together, blowing feathers, and all of a sudden there's p, k, a, and they start using phonetics, and they start to respond to the pictures and the words by one or two words. That could be enough to progress the child into one or two words, which is verbal. May not help them get expressive right away, but it isn't about becoming expressive and chatty right away. We have to understand that these children go in stages. It's typical for kids, and actually, I don't know it any other way unless they're a younger child where they just begin to spontaneously speak. But most children begin with quiet one or two words in different settings and then progress into more elaborate speech through the way we set up strategies and interventions, and we educate parents and teachers. And the children are also often very actively involved in their treatment as well. Sounds to words, as I said, go from simple sounds, silly, goofy sounds, chalk time in the backyard or blowing bubbles, to a very ritualistic putting sounds together to make words in a very charted, ritualistic, step-by-step fashion for that older child that's 8, 9, 10 or older who is conditionally mute or speech phobic, where no matter what you do, they're stuck against the nonverbal wall and they cannot progress into speech. The ritual sound approach is a very viable type of sub-treatment of SCAT that we use. Again, a transitional strategy. Augmentative devices using a tape and play method is often used in younger children just to have fun, their voice to be heard, or for school-based accommodations, interventions. It's usually used as a step into the progression of communication. It's not really a major treatment. It's just as a step that you don't rely on for long. Why? Because we don't want to rely on augmentative devices, and we don't want to rely on sign language for children long term other than an up, down, and simple sign gestures, because they have the ability to speak. Verbal communication is a child who can whisper quiet speech, scripted approach when they write and read, altered pig Latin speech for some children. It really doesn't matter, but if they're doing any verbalization, approximating words, that's verbal. Know that with 1A, 1B, 2A, 2B, 3A, 3B, it's about being responsive and initiative. So you can see here, I don't know how to focus on just mutism, because children are rarely just mute. They're in these different stages and different places that they go, and in different settings with different people all the time. So we need to know their baseline, and they begin to move across. So you can bridge down, but you will continuously bridge up to the point where they are consistently verbally responsive and initiative. Here are the golden rules. Some golden rules, there's others, but I picked a couple common ones here to go over with you. Social comfort precedes communication, and progress doesn't happen in a group. Make sense? In order to be communicative, you need to be comfy. Progress doesn't tend to occur in a group. So in a large classroom, if you're not comfortable with peers, you're going to see very minimal progress. So we want to do strategies and interventions by building social comfort, but doing them away from a full group. Social engagement via front line, meaning parents or teachers, especially parents, will place the child in front of them rather than on the side or in the back. Many of these kids tend to shadow, so we need to practice a front line goal for parents and a handover takeover goal, where the child is getting rewarded, or maybe it's just a parent prompts, hey, can you give the money to the store clerk? That could be incredibly scary for a child. So we will play games and do activities for younger children. As the child gets older, we're doing goals to help them hand over, take over. But let me ask you a question. Are they going to hand over, take over in a loud, large, lots of people environment, or are we going to do it in a place that they might have a vested interest in that's more safe for them, that's safer for them? So we need to think about where we do these games and goals, because it's where you do them that you're going to see success or not success, as well as how we talk to the children. Demystification is key. Acknowledgement and assessment. I can't tell you how many times I consult with professionals and work with parents where they tell me the child never knew why they were going for treatment. It was never really talked about. It was like the big pink elephant in the room. For me, I don't like that. Why? Because I feel children need to understand. That doesn't mean the first thing I say is, hey, you have SM and you're here so we can help you to communicate. No, not at all. But we start talking about things being scary. We talk about the bridge, and we talk about different feelings in different settings, and we start bringing it out to help them acknowledge and assess their feelings, because that sense of understanding creates control. So a big part of SCAT is giving control to a child where they feel out of control. We do that through structure, consistency, routine, predictability in the home life. We often feel some children need charts, behavioral and even calendar charts, because they need to feel in control. We help children understand their feelings by using feeling scales to different games and goals and back up into it. So if a child's not ready to understand, they don't understand their feelings or they're resistant, we'll back up into their feelings as we move through treatment, because understanding feelings is a critical way of building long-term coping skills rather than avoidant behaviors. Giving children choices in their treatment, meaning we set up the boundaries, like we're going to go play our games today because we've got to send Dr. E an update. Do you want to go? We can go now, we can go after dinner. So you give them the choices, but you set up the guidelines. That gives the child a sense of safety and control. Every aspect of their life should feel as if they have those kind of boundaries up, that they feel safe. Of course, that goes along with parenting styles and so forth. Charting. Charting is something that's done in a fun way for kids, and it gives them a sense of accountability. Families that come to our center know they're going to do some charting. You know why? Because it works. And the charting is based on where the child is. If you don't chart and keep track, how are you going to keep order as to what's going on? Because we want to keep moving forward like a GPS. You can't just say, hey, it's that away and hope they get somewhere. We need to give them a way to account for the games they're playing, and also to give them a sense of ownership of this, where they get it, they own it. So it's about transferring control to them, and that's really important in treatment. The importance of asking and answering questions. Do you ever think about this? You hear too often, I don't want to ask the child questions because it's going to make her anxious. Well, guess what? If you don't ask, they'll never have a chance to answer. It's at the level that they can answer. So we do question-answer activities in school with parents, with family friends, with peers in fun ways. We incorporate it into the school day. We incorporate it into play dates. We incorporate it into lots of ways to help the child begin to have the give, take. Because remember I said early on that many of these children go years without the give and take. So it's important to have the give and take of questions and answers so that the child begins to respond, but also learns to initiate. The child can respond by 1 or 2 words eventually, but also elaborate on something someone asks, because you need to be able to explain yourself if you have the ability. So that's very critical. Understanding the importance of the missing link or the transitional stage. Strategies are used to help the child move through the stages, but the transitional stage cannot be ignored if the child is stuck in the nonverbal and not progressing into speech. We're going to utilize that wonderful transitional stage. Minimizing a child's need to think and process. We ever really nervous, maybe really anxious for a variety of reasons, or one reason in particular, and someone asks you a question and you can't remember what they even said? Well, this is what happens to many of these children, that they can't think and process properly. So do they have a learning difficulty? I don't know, maybe, but some of these kids don't, that they just get anxious for a variety of reasons, some of their coexisting conditions. Maybe they have generalized anxiety, social anxiety, et cetera, but the anxiety, which is different for every child, causes the child to have challenges in their ability to think and process. So guess what? We're going to pre-plan. We're going to use repetitive activities. We're going to go to the same places over and over and do our games and goals. The same games that they play in school or same activities will be repeated at home in the school. We're going to use visuals to see and choices to hear. The more you see, the more you hear, the less you need to think. So repetitive activities are important. I can sit with a child and ask them a question like, what's your favorite pet? They know their favorite pet, but they may not be able to think to answer that, even non-verbally. So I will demonstrate two families in session how I will ask them these questions and the child's hesitancy becomes minimized. So they all of a sudden were hesitant in any response, even nonverbal. All of a sudden they're writing very quickly because they're in stage 1, but then all of a sudden they progress into speech and they're, what's your favorite pet? A dog. What's your favorite ice cream flavor? Vanilla. That's an example, what's your favorite questions, and you can use them a lot in different children with different give and take opportunities. But truthfully, that concept is what we need to create in all situations. Implementation is critical for success. I don't know how to get around that. If you don't implement, it doesn't work. It doesn't create consistency and progress. Often I hear from families, yeah, we do a little of this, yeah, we do that. Yeah, sometimes she'll tell me, well, it's like all over the place. So we need to have consistency through the different games and goals and charting and different things we do in a fun way that keeps accountability, but also implementing it. We'll sometimes do something called 100 times in 10 days, where we'll create these wonderful opportunities for these kids to do these games where they're feeling such success. And what do you think happens as they feel success? They cross the bridge into verbal communication because they're feeling confident and they're doing the activities that are based on their level of understanding, but where they are in the bridge. I just wanted to share this from a recent session. This was a little girl I was working with. She was about 8 years old, and we made a bridge in session. So working with helping the children understand the bridge, again, demystifying acknowledgement and assessment, and helping the child realize it's okay to point and nod. You don't want to create a situation where you can nod, you can point. It's not done that way. It's helping them understand the bridge, but we're going to use the strategies purposely to move them. So you don't want to keep them nonverbal, but you will be taught by the level that the child is at how to move them. So know that you don't tell the child you can do any of these 3 ways of communicating. We speak to the child in such a way that we will be promoting the next level across the bridge by how we word it and the games and goals that we use. Does that make sense? But their understanding of where they are on the bridge and at times moving down the bridge or moving up. So a child may be verbal with a friend and a parent when they're out and about, let's say in a family barbecue, but then all of a sudden another relative shows up they're not as comfortable with. You may have to bridge down to a transitional stage. So it's important to understand that bridging up and bridging down is going to be done based on the setting. Our goal is to teach parents and teachers how to be those implementers so that when you're not in the office, you're the one doing it. This other picture is a simple feelings chart. This is what we use to help the child feel, to help them understand their feelings. Young children tend to feel scared. Older children tend to say it's hard to do. So we'll use this. Remember when you first came here and we were playing the scavenger hunt game? You had indicated it was a 3. Now what does it feel like? And you're giving them the choices, and they'll indicate it's a 1. So things get easier as we do them. So we'll work on that throughout. This is just an example of some of the parenting goals and child-based goals that we use. And you can see that last picture on the right that this particular child took this chart out in the real world, and you can see that she was charting where she was on the bridge. Here's a very little girl, super excited to get rewards for the games that she's playing. She's playing all these games. Control for the charting, order, consistency, points for external motivation to play the games to cross the bridge. So what do you think is happening as she's playing these games? She's crossing the bridge. So this little girl's having a good old time, and she's showing off her chart. Obviously, the older the child, the more the chart is going to change. In school, we're going to build comfort and do strategies away from the group. We're going to do buddies, play dates with buddies, small groups in the room, small groups out of the room. Guess what? Every child, teen I work with has this. It's not unique. What is unique is how do you use the buddies, the reasons why the child's SM, where they are on the bridge, and their age. It's going to dictate how we use buddies, what we do during play dates with buddies, what we do in small groups, how we question the child, what visuals we use, etc., and what we do outside the room. So know that this is away from the group concepts as we can set them up and then we enlarge groups. And what the child's going to be doing in those smaller situations is going to be very different than in a larger group. So I'm just sharing here with you the study that was done on SCAT, that we had 40 participants between the ages of 5 and 12 years of age. It was over a 9-week period of time. And we used various measures to assess the children throughout the treatment. And this is just a list of them. The SMQ is a validated measure by Lindsay Bergman, so we use that to measure the child's verbalization throughout. The Social Communication Anxiety Inventory is an inventory I developed to help understand the stages and where the child is. The SM School Eval form and the parent follow-up form, we use this throughout our treatment. Every time a family comes for follow-up, they're filling out an SM parent follow-up. They're also teachers are filling out the SM School evaluation form as well. So we can see here that this was over a period of 15 weeks here we did post, and you can see here that the SMQ scores increased at each and every visit, which is awesome. It was statistically significant. Here, children with SM made significant progress in all areas of their life, home, school, and real world at each and every visit, and you can see here. But here's a really key slide. To me, this is the most important slide. Why? Because it works. Without a doubt, it works. We see it works. But guess what? The purple line is implementation. The blue line is they did nothing when they left the office. So you saw some improvement, and then when they stopped treatment, meaning the study was over, some continued, but some in this particular study didn't continue. We purposely didn't have them back for a visit. You could see that some progress actually went down a little bit because they weren't implementing. But the bottom line is it works, and children weren't in treatment for long. But look at those huge increases, meaning it works if you implement. But if you don't train teachers and you don't develop appropriate accommodations and interventions for these children and deal with the factors into their comorbidities into this, and you're just basically hoping for treatment in an office, I don't know how it can work. Parents need to implement. They need to set it up. They need to make it work. They need to know how to work with their child. This is the journal it was published in, and we can certainly send you it. It was the Journal of Clinical and Child Psychology and Psychiatry. So I thank you so very much. You can get more information from the SelectiveMutismCenter.org. I'm also very proud of Selective Mutism Association at selectivemutism.org. It's the organization I founded, and I'm a director emeritus. They have resources for you there, as well as treatment professionals in different areas. You can email me directly for the SCAT paper. I'm happy to send it to you. We have our new intensive group treatment. We've always had our intensive individualized program, but now we have a intensive group program, which 100% of the families rated it as excellent in our April camp, and 100% recommended the camp. Our next camp is August 11th to the 13th, and then we have October 7th to 9th, 2017. We are super excited about our camp, and we've had tremendous success with that. So I thank you so very, very much. My goal now is that you see mutism as a symptom and just one of the many characteristics that our kids manifest, and that SM is a social communication anxiety disorder. And we need to understand characteristics and coexisting conditions, and treating the whole child to develop a comprehensive treatment program in all areas of the child's life. I thank you so much for your time, and I'm so excited to have educated you.